All right. Hi, everyone. Good evening, and thank you for joining us. I hope everyone's been having a great week so far. I'm Dr. Mugno, and I'm a podiatric physician, and I'm happy to announce that I have joined Southeast Orthopedic Specialists. Thought I'd start off discussing a little about myself before I dive into what I'll be treating. I received my Bachelor of Science degree in Biomedical Sciences with a minor in gerontology from the University of South Florida. Shortly after graduation, I moved to New Haven, Connecticut, where I worked as a research associate at Yale University School of Medicine. And there I studied 30-day hospital readmissions. I then moved back to Florida, where I attended podiatric school at Barry University in Miami Shores, Florida. I completed 4 years of schooling there to get my doctorate in podiatric medicine. And then I decided to stay in Miami to complete my 3 years of reconstructive foot and ankle surgery at Jackson North Medical Center in North Miami Beach, where we also operated at Jackson Memorial Hospital in downtown Miami. So a little about me. I'm originally from Indian Harbor Beach, Florida, which is about 3 hours down the coast. My parents decided to move the whole family to North Florida when I was in middle school. So I ended up graduating here locally from Nice High School, big Tim Tebow fan. I have one fur child, as you can see on the left there, that's my dog Molly. And then I have 2 amazing nephews, Sebastian and Gio. They love being outdoors just like me. Basically, all my free time is spent when I'm not in the clinic is outdoors, anything from golfing, cycling, or to hiking. I recently went to Norway, so that's me hanging off a cliff there in Trolltunga. So over the years, I've fortunately have had the privilege to volunteer and perform various procedures and surgeries overseas. I was able to go to the Dominican Republic with Jose's hands, as well as the Yucatan Peninsula with Dr. Charles C. Sutherland Jr.'s Yucatan Children's Project, where we operated on neglected clubfoot deformities. And I've also been able to volunteer with the U.S. Air Force Auxiliary with Civil Air Patrol. So I will be based primarily in Fleming Island. I will be treating patients 10 years or older. And some of the most common problems encountered in the office include heel pain, ingrown nails, fungal nails, plantar warts, bunion deformity, hammer-toe deformity, neuroma, and diabetes. So before I dive in to all these common conditions that we see in the clinic, I just wanted to do a quick review of the anatomy of the foot. So as you can see here, we have 28 bones, 107 ligaments, and ligaments are these fibrous connective tissues that connect bone to bone. Then we have 33 joints, 19 muscles. So you can see that the foot has a lot of intricate parts that need to work harmoniously in order to function properly and without pain. So I'm going to start off with heel pain because approximately 2 million Americans are diagnosed and suffer with heel pain, specifically plantar fasciitis, which I will also dive in deeper in the following slides. But some of the causes of heel pain include abnormal gait, which is gait is the pattern that you walk, obesity, poor shoe gear, high impact activity, stress fractures, bursitis, nerve enlargement, and then certain conditions such as diabetes and arthritis, which I will also dive in deeper later on. So as I mentioned, the most common form of heel pain is plantar fasciitis. We see this multiple times in a day. And this is basically when the plantar fascia becomes inflamed. And the plantar fascia, as you can see in the picture, is a thick connective tissue which supports the arch of the foot, and it spans all the way from the ball of the heel of the foot and then expands to the ball of the foot. And so any excessive pressure on this plantar fascia can create damage or little micro tears, which cause inflammation, which is why the patient typically feels that pain in that region. So plantar fasciitis most commonly affects those between the ages of 40 and 60. And unfortunately, there is a predilection for women versus men. We also see risk factors with those who have tight calf muscles, those with obesity, individuals who participate in high impact activities such as running or basketball, as well as the foot structure. So unfortunately, the foot structure that you were born with, flat-footed or having a high arch even, this can adversely affect the weight distribution when you're standing or walking, which can also predispose you to plantar fasciitis. So some of the symptoms a patient may experience when suffering from this condition include pain on the heel of the pain on the bottom of the foot near the heel. Patients will often complain of severe pain with the first few steps after getting out of bed or when they stand after a long period of rest. Typically, the pain subsides with walking, and typically the pain will also increase after activity or exercise versus having pain during the actual activity. So this condition is self-limiting, meaning it typically resolves on its own with proper treatment. And if it doesn't resolve, then we can always go to a more surgical approach. However, most of the time, like I said, conservative measures were able to hopefully alleviate most of the pain, if not all. So we typically will start the patient on a very intense stretching regimen, some activity modifications, rest, of course, icing. We'll modify the shoe gear and make sure that the patient has a shoe that has a more stiffer sole, so it's therefore more supportive for the foot. We also can discuss weight reduction, over the counter or custom insoles. And these are all forms of conservative treatment, like I mentioned before, that we try to exhaust before we ever have to bring you to the OR. But in the case that you do have to go for surgery, this is an outpatient procedure. It takes less than 30 minutes and you're out the same day. We also see a lot of ingrown nails. So this occurs when the nail grows into the skin of the nail groove, or the skin on one or both sides of the nail grows over the edges of the nail, as you can see in the photo. This will lead to some redness and pain and swelling in that area. And occasionally it can lead to some infection. So patients will typically experience maybe some drainage, clear drainage, or maybe more like purulent, milky drainage. I commonly get asked this when patients come in. So what causes an ingrown nail? And there are several factors, but two of the most common, I would say, is the improper trimming of the nail, as well as wearing ill-fitting shoe gear. So shoe gear that is maybe too tight or too narrow, that is pushing your toes together so that there's constant pressure in that area. Also, sometimes it's congenital. You're just born with a larger toenail than your foot would like. So that can cause some issues as well. Trauma, if maybe someone steps on your foot or you stub your toe, that can also cause an ingrown nail at times as well. And then last but not least, poor foot hygiene. So for ingrown nail treatments, these are procedures that we do in the clinic. They're pretty simple. I usually say the hardest part is the local anesthesia. We will perform a block on whatever digit is affected, so whatever toe you're having this condition with, and it will be completely numb. We then resect or cut that nail border that is growing into the skin. And if this is a more chronic issue, meaning you've been dealing it with multiple times and you're kind of just wanting to do something more permanent, we offer something called a matrixectomy, where we introduce a compound into the nail where the nail grows, and that prevents the nail from hopefully returning. That's our hope. But this way you don't have to deal with it for at least some time. And post-procedure is super simple. You return to work the next day. If it is infected, we can prescribe you some antibiotics, and it's pretty simple after that. We also see fungal nails. This is also known as onychomycosis, and this is an infection of the toenail caused by fungal elements. New evidence is showing that the majority of fungal nail infections are associated with bacterial infection as well. So a lot of patients come in and they want to have this fixed due to the way that it progressively discolors and thickens the nail. And as it progressively thickens and gets discolored, it also becomes more brittle and it's more fragile, so they crack or break or crumble. And typically it's also common to have a concomitant fungal skin infection. So these can typically also be treated with creams or topicals. There's several different treatments out there. There's also oral medication as well, but those have some side effects for your liver. So we try to start conservatively with the topicals, and then if we have to progress to oral medication, then that's something that we can discuss. So I frequently get asked this question, why do I have fungal nails? And the truth is, anyone can get it. So I shouldn't say anyone, because typically we don't see it below like the age of 6, but after that, anyone can honestly get it. Patients who suffer from chronic diseases, such as diabetes or have circulatory problems or immune deficiency conditions are especially prone to getting fungal nails. Like I said before, if you've had any nail injury, that can easily introduce bacteria or fungus into the nail. Also, climate. We live in beautiful Florida, and unfortunately, it's hot and humid here, and that increases our risk for developing infection with fungus just because it thrives in this environment. So last but not least, our lifestyle too. If you're spending time in the water a lot, or if you're a smoker, unfortunately, things like that can also predispose you more to fungal infections. So how can I prevent a fungal nail infection? You want to start by keeping your feet clean and dry. If you have hyperhidrosis, which is of the feet, which you sweat a lot with your feet, you can always pack. I always advise packing an extra pair of socks and switch them out midday. Alternating shoes, for example, if you wear sneakers, your Nikes or Nike sneakers one day, the next day wear your other sneakers, your Adidas sneakers. So rotate, so you give them some time to air out. Keep your nails short so that no debris and things can get stuck underneath your nails and potentially cause an infection. Do not walk barefoot in public areas. If you do have to, make sure you're wearing, avoid wearing flip-flops or something if you're in like showers, locker room type of situations. If you are going to a nail salon, make sure you go to one that's licensed by the state and they practice safe hygiene and you see that they're properly sterilizing the tools that they're using on you. Other things you can do, you can use antifungal powders and sprays. If you do have athlete's foot, you want to get that treated as soon as possible too, because that can also affect your nails as well. And then last but not least, do not share shoes with other people, nail clippers, towels, and other personal items. All these can spread the fungal nail infection. So fungal nail treatment, it can be difficult to cure. It does take some patience. In the clinic, we can do some debriding of the nail and then initiate a topical treatment, as I had mentioned earlier. There are also medicated foot soaks tailored to the specific components that might be infecting your nail. There are also oral options, as I had mentioned before. However, there are some side effects. And then last but not least, this is kind of like a last resort, temporary or permanent nail removal. But hopefully we can exhaust these other measures before it comes to that. We also see plantar warts. So these are small skin growths on the bottom of the foot caused by direct contact with the human papillomavirus. People with a weakened immune system may be more susceptible to developing plantar warts. They may be solitary, meaning there may be just one, or it may be mosaic, where you see a kind of like a cluster of them on the bottom of your foot. And so symptoms for these include pain, as I said, thickened skin. You'll maybe see some tiny black dots within those thickened skin regions, or you'll see whiter skin colored lesions on the bottom of your foot. So next we have the bunion deformity. So this is a very common progressive deformity, meaning it can worsen over time. Patients present with this painful bump on the side of their foot. More than 30% of older adults actually have this deformity, and research from the Journal of Arthritis Care and Research recently found that bunions are about 60 to 90% hereditary. So you can definitely thank your family members for that one. Shoe gear can play a role, and they typically present around between the fourth and sixth decade of life. So we also see and treat a lot of hammer toe deformities, and these are usually in conjunction with the bunion. This is a condition where essentially the toe is bent at one or several joints, and usually it's in the lesser digits, meaning 2, 3, 4, and 5, not your big toe. It can be caused by muscle imbalance, a traumatic event, or wearing improper shoe gear, such as shoes that are narrow towards the toe, which then cause the toe to bend. So symptoms for this include swelling, redness, inability to straighten the toe, painful corn or calluses at the end or top part of the toe, and then irritation when wearing shoes or even difficulty walking. Next, we have corns and calluses, and these are hard, thickened areas of skin caused by abnormal mechanical stress on the skin. And this results essentially from an accumulation of the epithelium, which is the outer layer of the skin, building up. But it's essentially a way that your body protects itself from the extra pressure. So we advise never to cut the corns or calluses yourself. Give us a call. We're more than happy to safely remove them, and we can discuss treatment options that are available to prevent that reoccurrence, so you don't have to experience that pain over and over again. We also have Morton's neuroma. So a neuroma is a thickening of the nerve tissue, and this can occur from compression or irritation. Morton's specifically is the name we give this condition when it's located between the third and the fourth toe, which is typically seen due to crowding of the anatomy in that area. We often hear patients describe the pain or symptoms as walking on a pebble. Typically, pain increases with walking and decreases with rest or whenever one removes the shoe. And with these, it's super important for early diagnosis. So it's key to greatly lessen the need for a more invasive treatment and may help you avoid surgery. So last but not least, I see a lot of diabetic foot care patients. So people living with diabetes are unfortunately at higher risk for having foot problems. And this is often because of two complications. So one, neuropathy or nerve damage, which I'll kind of go into more later too as well. This causes the loss of feeling in the foot, taking away the patient's ability to kind of feel pain or discomfort, or even their ability to detect if there is any injury. So they're not able to basically sense, for example, if they've stepped on a nail or if they've broken their great toe, which seems crazy, but it's unfortunately one of the side effects of neuropathy with diabetes. Second, poor circulation in your feet also is a complication of diabetes, and this reduces your ability to heal, unfortunately. So this makes it hard for even the smallest wounds, such as like a tiny cut or a small blister, to resist infection. So a little more about diabetic peripheral neuropathy. This is a nerve damage that's caused specifically by the high blood sugar levels. So this affects the sensory nerves, which is what I was discussing before. This enables people to feel pain or temperature or sensation. It also affects the motor nerves, which these nerves control the muscles and give them their strength and tone. And lastly, the autonomic nerves. These allow the body to perform certain involuntary functions, or functions that we don't have to actively think about, such as sweating. So that's why we typically see that patients with diabetes may have some dried, cracked skin. Symptoms typically present usually in the hands, feet, or legs, include numbness, pain, burning, or like a tingling sensation. So the best way to prevent progression of this condition is to be proactive about your health. You want to monitor your blood sugar levels and keep them under control. You want to wear proper shoe gear at all times so that you're protecting your foot from any injury and thus preventing any possibility of getting a type of wound or stepping on something that would cause some type of injury. You want to inspect your feet daily. You want to have periodic visits with your primary care physician or endocrinologist. And then, of course, you want to visit your podiatrist with regular appointments and make sure that you're having your feet examined and that they're in good health. Last but not least, I did want to talk about diabetic ulcers just because I did a lot of research and time working with diabetes and diabetic ulcers, but just a definition, ulcer is an open wound or sore that can be difficult to heal. 25 to 50% of diabetic foot infections lead to minor amputations. So minor amputations are toe amputations, and sometimes 10 to 40% require major amputations. So this is a amputation to the foot or the leg. And about 10 to 30% of patients with a diabetic foot ulcer will go on to amputation just in general. So one of our main goals is to prevent any ulcers, as you can see. So that's why it's so important to make sure that if you're a diabetic patient that you see a podiatrist regularly. So just a recap, I will be practicing in the Fleming Island Clinic. So if you'd like to schedule an appointment, that's where I will be Monday, Tuesday, Wednesday, and I believe Friday now. I will also be operating out of the Ascension St. Vincent's in Clay County. So I'm excited for that. This is my contact info here. So if you have any questions about any of the material here too, if you'd like to discuss anything, feel free to contact me there. And I believe we are going to go into the question part of the seminar. So I get asked that a lot, and yes, they are. So if you are experiencing a plantar wart, or if you think you might have one, make sure that you are protecting those around you or those that may live with you. If you are sharing a bathroom, for example, the shower, make sure you're spraying that with some type of bacterial disinfectant. They are very contagious, so make sure you're wearing house shoes or something so that you're not spreading that to other people. So fractures typically take about 6 to 8 weeks to heal, but I will say there are other factors. So for example, if you're a smoker, there's a lot of research on that showing that, you will have delayed healing, versus if you are a child, children are more resilient. They typically tend to heal closer to the 6 weeks or less. Also, if you have like any comorbidities such as diabetes, that can also prolong your healing time as well. Yeah, we're able to do that. We have custom made orthotics. And so what we can do is something called a scanogram. And this is basically where they do an X-ray of your entire body, and then they figure out exactly how much of a difference there is in your limb length. And then we are able to put that into your order so that it should be able to even you up a little more. So shoes do aggravate bunion development, but it's essentially your genetics that make you susceptible to them. Tight shoes are shoes that are too small, that may crowd your foot. These can all put pressure and kind of make the deformity progress at a more rapid rate, but it's not necessarily the shoe gear itself, it's more so the genetics. So for calluses that are recurrent, typically we advise if the patient is healthy, using a pumice stone and rubbing in that region. We can also prescribe some moisturizers that are prescription grade to kind of help slow down the progression. Certain calluses, such as IPKs, which are kind of little clogged sweat glands on the bottom of your foot, calluses such as that, those can be treated with certain chemicals to kind of prevent it from ever reoccurring again.